Hello, I'm Dr. George Rutherford. I'm a professor at the University of California, San Francisco, and I'm here to talk about epidemiology, surveillance, and strategic information to give you some very high level concepts and to try and define them for you. So, we're going to talk about key concepts. We're going to try and define populations, give some examples of various surveillance methods, talk about data sources for surveillance and strategic information, talk a little bit about analysis, interpretation, and applications of surveillance and strategic information, and a few things around epidemic control and getting to zero. Epidemiology is the study of the distribution and determinants of health-related states, what we typically call diseases, although they could be events as well, among specified populations and the application of that study to the control of health problems. So you can see here in a graph, we've plotted four things at once: the total number of people living with HIV, that is the prevalence of HIV; new HIV infections, that is the incidence of HIV. The red here is the HIV-related deaths, and the orange bars represent people on ART. Obviously, as we go out into the future, this gets better and better and better. Surveillance uh, tries to provide basic data for descriptive epidemiology. Now, by descriptive epidemiology, I mean looking at single variables. So the number of cases over time, the number of people with a certain condition over time, those kinds of things. How many cases were there in a certain city? Okay. So we typically include what we call descriptive or demographic data about the person, their age, their sex, their descriptions like occupation, for instance, a place, which can be anywhere from a region to a country to a subnational region to a city to a neighborhood to a block. We also look at time, which can be dates, hours, months, years, days. And then what exactly is this, a health event or is it a disease? So, for instance, pregnancy is not a disease, it's part of normal physiology. So, births are a health event and are not a disease. Diseases are things like HIV, infection like SARS-CoV-2 infection, like COVID. Um, and then the other thing to point out is that epidemics and their contexts differ from place to place, right? So knowing who's infected, how they became infected, and where they became infected are crucial for us to target public health interventions. And then on top of that, once we start targeting them and once we start trying to intervene to prevent disease or to get people into treatment, we need to monitor what we're doing to maximize its effectiveness, responsiveness, and cost effectiveness. So surveillance is defined as the ongoing systematic collection, analysis, interpretation of health data for the following ends: to measure disease burden, to identify and control outbreaks, to measure the impact of interventions, as we talked about just a second ago, and to plan programs and allocate resources. We talk about just the disease burden in terms of the magnitude, that is the number of cases, the populations and characteristics of infected populations, infected persons, the geographic distribution, and then trends over time. This was just looking at, for instance, the number of people living with HIV in various cities across the world. So strategic information is a higher level concept. Strategic information uh, is the kinds of information that includes surveillance and monitoring and evaluation, the kinds of information that's interpreted and used for planning and decision making to improve the direction and focus of a program. So here we can look at this city-specific reported data from the Global AIDS Response Progress Report for 2016. Here we have city and national level data and looking at PMTCT coverage, for instance, here in Nairobi versus the rest of versus Kenya as a whole. So SI addresses not just epidemiology, but also service access, coverage, quality, and acceptability. And so it's a concept that's kind of above the level of surveillance, as I said, and it can lead to deeper understanding of the context of the epidemic, the vulnerability of certain communities, the risk exposures, the options for actions to alleviate burden or to mitigate the impact of the disease. So SI should be systematically collected, consolidated, analyzed, and applied just like surveillance, right? And the point is here is that we're trying to support evidence-based decision-making at all levels of the health system. You need to know what's going on in order to make good decisions. To support the development and implementation of systems to produce valid, accurate, reliable, and timely information, you have to have a feeder system in order, if you're going to get good information, you have to work on the information system. To provide valid, accurate, reliable, and timely information for use by relevant stakeholders, same point. Support the harmonization and standardization of information collection, management, flow, and use. And I don't need to tell you that your different funders have different expectations, different lists of things they want to have done. And you could spend your whole life doing nothing else but filling out forms for your various funders, trying to get that stuff harmonized, trying to get it standardized, trying to get it down to a dull roar, so that the collection, management, flow, and use are much more efficient is a huge part of this. And to strengthen the transparency through dissemination of data, information, and knowledge in a timely manner. So information is power. We want to get it out to the people who are providing it. We want to get it out to the people who are using it, and we want to get it out to the people who are affected by it. So in supporting programs through results-based planning and implementation, SI plays a role in understanding the epidemic and the extent of change resulting from intervention. So here's time one, here's time two, what's happened over that period. Tracking, engaging the health sector's response to an epidemic, the health system inputs, intervention coverage, quality of services, outcomes and impact, et cetera. By informing program improvement, which includes assuring quality and maximal return on resources invested and helping to identify bottlenecks and opportunities. Now, just a couple of words about populations. We throw these terms around a lot in HIV epidemiology, and they're often undefined, but I wanted to kind of take this sort of chance to walk through this with you. So the general population refers to everybody. Often with HIV, this is limited to people who are purportedly sexually active. So it's often limited to adolescents and adults 15 years and older. A key population is a subset of the general population, and there are often several key populations, plural. They're defined as groups who, due to specific high-risk behaviors, are at increased risk for HIV, irrespective of the epidemic type or local context. They often have legal and social issues related to their behavior that increase their vulnerability to HIV. So this isn't women married to men with HIV infection, right? That's only going to happen in generalized epidemics. That's largely happening in a certain group of countries, and it's not really across the board. But it's this kind of group membership in vulnerable groups that changes that dynamic. So what the key populations are that WHO considers are men who have sex with men, people who inject drugs, sex workers, transgendered individuals, and prisoners. Now, I just want to show you this to try and sum all this stuff up. We're looking here at, we can move from here. What's the problem? That's the situational analysis and surveillance. To try and understand this stuff, what interventions can work, what are the contributing factors. This is often based in research. This is kind of things that are known or in guidelines, what interventions are needed. These things cost stuff. You got to do the input planning and stuff. Then we move into activities. What are we doing? Are we doing it right? That has a lot to do with QI and quality assessments. Are we implementing the program as planned, right? And are the interventions working or making a difference? So these are kind of outputs here, and then outcomes here. What are we seeing? Are we seeing changes in the, for instance, the number of cases, in the incidence of HIV, in behaviors, whatever we're trying to target? And then finally, we can come up here to look at impact, which is asking the question, are collective efforts being implemented on a large enough scale to impact the epidemic, meaning in terms of coverage and in impact? And that's called outcomes and impacts monitoring. All this stuff then feeds back. We identify new problems, things that aren't working quite right, and then we work them up through the system again. Now, PEPFAR is defined as its own definition of epidemic control, which is the number of new infections that it's the total number of new infections that falls below the total number of deaths from all causes among people living with HIV, with both declining. So if you had, for instance, new infections going up and deaths going up, that's not epidemic control, even though the lines may cross. So they both need to be declining, and you want to have fewer new infections than deaths from all causes among people living with HIV. UNAIDS has its own goals that complement PEPFAR's. They're attempting to achieve the 90-90-90 goal targets this year, with fewer than 500,000 new HIV infections per year, fewer than 500,000 AIDS-related deaths, and elimination of HIV-related discrimination. Notice here that this doesn't say all deaths among people living with HIV. It specifically says AIDS-related deaths, so this is different from PEPFAR. By a decade from now, the vision is to eliminate HIV as a public health threat, to achieve the 95-95-95 targets, and to have fewer than 200,000 new infections per year. Thanks. I'm going to stop, and I'll come back to you on the next one.